Hello everyone and welcome to Module 6. This week our focus will be on pediatrics, and on the topic of pediatrics we only have one chapter that we are looking at, and that is the chapter 40. So this whole unit, this whole week, we will only be talking about chapter 40, so shouldn't be hard to read this one chapter for you guys. So let's go ahead and get started as there's a great deal of things to cover. Now, as a medical assistant, you need to have an understanding of the unique circumstances and considerations involved with pediatric patients. Even if you're not planning to go strictly into pediatrics, the providers that you work for may still see some pediatric patients, either in family practice or in a specialty. So it's important that you have a good understanding of how to deal with pediatric patients. Now, a pediatrician is the typical physician who specializes in the treatment of newborns, infants, children, and adolescents. Pediatricians can see patients who go from birth up to age 20, but then they typically recommend that that patient find a new primary care provider. Now, when we begin to discuss pediatric patients, it's important that you learn how to communicate with them. Communication is essential in any component of patient care, but with pediatric patients, this can be very challenging. There are a few things to keep in mind when you're communicating with a pediatric patient. First and foremost, you want to smile. All patients, especially that of infants and children, are very receptive to a warm and friendly smile. This makes them feel welcomed and feel like they are okay. Communicate at their eye level. Maybe that means that you need to sit next to them or crouch down in front of them, but you don't want to talk over their head. Get down to their level and speak with them. Speak in a gentle and calming manner, but that doesn't mean that you have to speak baby talk. Okay, you want to still use bigger words that kids can understand, but just tailor it to their actual learning. You want to make sure that your voice is in a calming manner, because if you feel stressed, children will feel that as well, and that will set off their anxieties about being at the provider's office. Never lie to your patients. Now, this obviously applies to all patients across the board, but you never want to lie or fib to a peds patient to get them to comply with you. You also don't want to bribe them, okay? Pediatric patients are just like any other patient, just in a smaller sector. And always take time for role-playing. So role-playing is really a tool that you can use to help you prepare to deal with a situation when your peds patients may be upset or may be resistant to care. But allowing them to touch some of the equipment that they can also helps to set some of their fears aside. So maybe letting them play with the stethoscope or hear your heartbeat or hear their own heartbeat might help to make that process a little bit easier, as well as making them less fearful about being at a provider's office. So now that we understand the ways to communicate with our pediatric patients, let's discuss the actual office setting of a pediatric office. So when you're working in a peds department, there are a few factors to consider. First and foremost, the office reception area should be bright and welcoming. This is to help make your patients interested in being at the provider's office, but also helping them to feel more relaxed. You want to stay with what would be your primary colors, but make sure that they are bright. Your office should also have some cartoon characters or an animal theme to really help bring that childlike atmosphere to life. Every child likes animals and every child likes cartoons, so making that a fun environment for them will make them happier to be there. Also, have some toys or books or coloring spaces that when they're waiting for the provider, they can be entertained with those things as well. But along with that is that you want to make sure that you are putting the patient's safety first. Once a child enters your office, their safety is your primary concern. You never want to leave a child alone on exam tables or scales, or even if you're helping them to go to the bathroom, you do not want to leave them alone excuse me, on any sort of area that could be potentially dangerous. That's why we always have signs that will hang in the patient's rooms saying, don't leave baby on the table alone. You want to stay with them. So we've talked about our office. We've talked about what the role in pediatrics is, but let's actually talk about the patient itself. Growth and development refer to the changes that occur in a child's life as they grow and mature. This is what we are actually paying attention to in that pediatric office. Okay. And with that, when we talk about development, it refers to the motor, mental, and social progress of a child. But it's important to know that children mature at different rates and at different stages. They should all pass through stages consistently as they age and in different age range that are specific for stage development. If there's a problem, the earlier that we detect it, the better the outcome actually is for the child. That's why it's important that at those yearly visits or at those monthly visits or at those well baby visits, we're actually going through, can baby grasp? Can baby sit up straight? Can they hold themselves up? Asking those questions to see developmentally how they're growing. Now, one other thing that we do is immediately after birth, newborns are assessed using what we call an APGAR score. Now, APGAR looks at appearance, pulse, grimace, activity, and respirations. It's a method of really evaluating a newborn's condition, and we do that at 1 minute and 5 minutes after birth. The higher the APGAR score is, the healthier the newborn is. 9 is actually the highest score that a newborn can reach, and they want to receive that. But anything that is less than 7 in those first 1 and 5 minutes, the newborn needs to be evaluated every 5 minutes for 20 minutes. And the provider may actually intubate the baby if they have 2 or more scores that are not 7 or higher. So that's something to keep in mind. You may never have to deal with an APGAR score because we don't typically work in hospitals, but it's important that you know what an APGAR scoring is. So let's talk about some office visits that pediatric patients will come in for. And it's typically one of two. It's either a well baby visit or a sick child visit. And both of them contain very similar sections to each visit, but are 2 very different visits. So during a well child visit, what we're doing is we're looking at the growth and development and measuring them, as well as giving them immunizations and health information. Your well baby visits typically start after the birth, and it's 1 month, 2 months, 4 months, 6 months, 9 months, 12 months, 15 months, 18 months, 24 months, and then every year after that. And because we're looking at growth and development, as well as measuring the baby, we want to look at how they grow, because on average, a birth weight for an infant is about 7 pounds. And by their 6-month visit, that should have doubled. Okay? If that doesn't happen, what we do is we start to look for what we call failure to thrive. This means that the infant is unable to gain a sufficient amount of weight according to the standard baby growth charts. We also take measurements at every new well baby visit, and just like any other patient, we have to take their vital signs, but there are some differences. For example, we take a temperature, but for any patient under the age of 5, we should do this either in the tympanic membrane, the temporal artery, or your auxiliary. Pulse in children, typically 2 and younger, should be done at your apical pulse. And infants typically have a higher pulse rate of 100 to 160 beats per minute, and this will slow down as they grow. Respirations are easy to count because you can visibly see the child's chest rise and fall. The younger the child, the higher the respiration rate. So for example, your infants and newborns will have 30 to 60 breaths per minute, where the average adult rate is 12 to 20. Now, blood pressure for most pediatric patients is not required unless the child has a heart or kidney disorder. But typically, once they turn 5, once a year we should take their blood pressure. And make sure that you're using a pediatric cuff. Height and length should be taken at every visit, and we want to do this without their diaper. This helps us to ensure that we get the most accurate length or weight. And length of an infant should be taken on an exam table, or if your scale has one attached to it. Head circumference is a measurement that also is taken on pediatric patients, and we do this up until the age of 6. And what you'll want to know is that a normal head circumference is anywhere from 12.5 to 14.5 inches. We also take a chest circumference, but that is only if the provider suspects any sort of under or over development of the heart and lungs. And once we do all of those things, we will then plot this on a child's growth chart. They are available for both boys and girls because they grow and mature at different rates. We have to have 2 separate ones. We have ones that go from birth to 36 months, and then 2 to 20 years. Sick visits is when the child is ill and brought in for diagnostics and treatment. You would do all your normal vital signs like temperature, pulse, and respiration, and always, again, height and length, or weight and length. But you could also be responsible for helping to collect urine samples, maybe administering a nebulizer treatment, or even holding the child so that way diagnostic tests can be performed, like a flu swab or a strep swab. Now, the last thing that I want to talk about here for this video is adolescence and puberty as well. So adolescence is a transition period between adulthood and puberty, and it's divided into 2 stages. The first one is called early adolescence, and this typically happens between ages 12 to 14. This is when puberty begins and the development of secondary sexual characteristics happen, such as the development of body hair, breast development for females. The menstrual cycle starts for females. You can see that boys are starting to grow maybe beards or facial hair. They'll also have their voice changes. And they'll also develop some muscles that they didn't have before. Now, during this stage, your patients may be difficult or uncooperative. But what we need to remember as medical assistants is we've all been there. We've been at that stage, and we've been those unhappy teenagers. So help them and work them through that, but also don't get frustrated with them. Then we have middle adolescence, which is typically for girls. They are physically mature at this point, and boys are still maturing. And body image for them is very important and often their primary concern. So because of that, we need to be cautious and watch for things such as eating disorders, either anorexia nervosa or bulimia nervosa. Alright guys, that is what I have for Module 6 and Chapter 40. Again, as always, please make sure that you are reading your chapters in full, as I don't really discuss everything in the chapter. So it's important for you to know those things for discussion boards, quizzes, written assignments, as well as your CMA exam. Now for your homework this week, you have 1 assignment, and that assignment is on the subject of immunizations. The assignment should be at least 1 to 2 pages in length in proper APA format, and you will need to submit that no later than Sunday, August 13th. Have a great week 6, guys. Bye-bye.